Now to session 4, and we're doing pretty well for time here, and I see session 4 coming up. So session 4 is about our manufacturer viewpoint. And what's interesting about all 4 of our panelists is that while they have records, and I might say stellar records in industry and primarily the life sciences, they are now having different kinds of jobs that draw on their background in the life sciences and more conventional companies and so forth to doing some really cool stuff these days. And part of our discussion is going to be some reflection on what has happened to date. And some of it also is going to have to do with now that you are in your new respective new positions, how do you carry forward their experience in VBID from industry to do something kind of new and different from your new pedestal? So let's handle it that way. Muna, I'm going to ask you to start. Muna, if you could just reintroduce yourself, remind us what you did and what you're doing now, ever so briefly, and how did you first encounter VBID? Muna.
Sure. So thank you for having me. And I have been at Merck for 34 and a half years. Just 6 weeks ago, in fact, left the company. I retired from Merck after a career there that has lasted a lifetime, and am now a senior advisor and a board director within the biotech industry. And
Excellent.
I find myself in this space as a result of the work that we began at Merck. When we started to look at how we solve for the affordability issue. And it's very clear when we're talking about affordability for patients, they care about what they pay out of their pocket, which of course means you have to solve it through benefit design. The other place we came from was taking a look at how headroom can be created in the health system to pay for the innovations that are coming out of the industry. And of course, you cannot get to that decision without beginning to deconstruct what we look at as wasteful care. And that was a part of our connection with Mark and the team. And then the last piece was, you know, we started to look at our own spend and in terms of the population at Merck. So Merck not as a pharma company, but Merck as an employer, paying as a self-insured, the company paying the bill for its employees. And we applied the VBID-X principles to looking at cancer care in the population at Merck, what drove the spend, what drove the outcomes, and where were there inefficiencies in that context that we felt that we could get out of the system. Because, you know, it's one thing to go and talk to our customers about inefficient care. The first thing they will ask us is, well, what have you done to get after that inefficiency in your population as an employer? And so that was also a part of our work. And while I'm here, I have a number of my colleagues. So Kathy McKeon and Brian Keehan are on the are on the participant list here. So a shout out to them and a shout out to Sharif as well.
Thank you very much, Muna. It's noteworthy that VBID had some appeal not only from the standpoint of being one of the leading life sciences companies, but looking at your valued workforce and how would they be faring here. So point well taken. And before I leave you, just kudos to your former company. It did not go unnoticed here, how they hooked up with J&J. Very nice service to the country. So kudos to them. Christine, interesting. You also came from a life sciences background. Tell us a little bit about what that company was, what you're doing now, and what the original hook was with VBID.
Sure. So like Muna, I retired after 22 plus years at Sanofi, and I guess probably lots of experience in market access, in working with the employers. Shout out to Jill and the work they did at Marriott and the Pitney Bowes folks. That laid the groundwork for a lot of the early discussions with health plans, with health systems, with employers on these topics around, population health issues that were raised earlier around diabetes, heart disease, et cetera. That was probably 13 plus years ago. And now I'm currently a vice president at Discern Health, and we work with life science companies and other organizations to look at the quality and value environment in healthcare and help them make, better solutions and impact the market differently.
Excellent. Thank you very much. So you're applying some earlier experience from Sanofi Ford, also a highly innovative company, must say. Thank you. Josh Hoffman, you come from a pretty well-known company. Now you're doing something ultra cool. Tell us about it, Josh, and then tell us what your connection to VBID has been.
Yeah, well, maybe I'll start just kind of how I got connected to VBID. I mean, my background, I'm a physician and a health services researcher where I spent many years studying the quality of care, which includes things like overuse, underuse, misuse, necessary care, and got in touch with Dr. Fendrick and colleagues many, many moons ago to begin to look at that dynamic. And then I joined Amgen out of academia. So I was in biotech for about 16 years. And it became very clear that part of the mechanisms for trying to address the drug spending and drug pricing issues had to do with shifting costs to the patients. And in many respects, we began to study how that was just undermining appropriate utilization and high quality care. And then it became very clear in that journey that the benefit design, as Medicare Part D was enlisted with a donut hole and a lot of patient cost sharing in some of our most vulnerable patients, that they weren't using the medicines that they needed to achieve good outcomes because of the cost sharing. So value-based insurance design became such a prominent feature. How do we think more clearly about insurance designs for particularly for the interventions that are the most meaningful for patient outcomes? And so this idea of of dealing with the deductible, but also the co-insurance and the cost sharing around very specific high value interventions really shone a light on this disparity between or discrepancy between low value care and high value care. So, following Dr. Fendrick and his work for so many decades now, that we at Amgen actually implemented a value-based insurance design program in our employee population. Like what Muna said, at Amgen, we began to focus on our own employees and that they were also suffering from those insurance designs and not taking the medicines they needed. So we worked with Mark, we worked with our PBM and Amgen, and we actually created a value-based insurance design program for those who needed biologic therapy for serious conditions. And it was actually very well received, run very successfully. It's still in place. I now have joined a company called Grail. I'm the chief medical officer and head of external affairs there. And this is a company dedicated to really changing the paradigm of how we find cancer early. So it's the idea of multi-cancer early detection using signals in the blood. And again, that raises a lot of questions about our oncology care and how we're spending our money and what we're doing. And as you know, most cancers are detected too late in their late stages, where outcomes are very poor because we're not looking for most cancers. We only screen for about 4 or 5 cancers in this country, yet 70 to 80% of the deaths are occurring in cancers we're not looking for. So we now have innovative technology that can change that. And we think it's probably the best way of bending the mortality curve in cancer. But again, if you look at benefit designs in Medicare, for example, screening for cancer is not a covered benefit. So there, everywhere I look, everywhere I go to facilitate innovation getting to patients, we have to look at our benefit designs and our coverage policies. And that's why I'm excited to be here today.
Great, thanks, Josh. And we may ask you in a little bit to return to that for this kind of high-end screening. It's kind of a specialized area, and is that compatible with some sort of VBID application? May want you to opine on that. Mark Staubach, great to have you as well. Remind people what you did, what you're doing now, and your connection to VBID in any order.
Sure, thanks, Cliff. I'm glad to be here. I'm a biopharma industry consultant now with typically small, earlier stage biotech companies, either launching their first product or planning to and trying to navigate all the complexities that we've talked about today to ensure access. Prior to this, I spent over 30 years in the industry, from small startup biotechs to large pharma and a variety of different commercial roles. My involvement with this goes back a long way, I guess. Well, the center was a twinkle in Mark Fendrick's eye, maybe just after that lunch at the famous Kang restaurant. Mark was on an ad board with the company I was with and started talking about benefit-based copay. And I said, I like the idea, but I thought there were a lot of complexities in between in the distribution and reimbursement and third-party payer system and rebates and everything else that made it even more complicated. So he said, great, I'll send you the paper, take a look, give me your comments. And I was unknowingly drafted into this movement, I guess. I think at one point early on, I even helped him draft the copy for the First Center website. So he asked me to be on the ad board. I've been involved ever since. And I'll just say that while then and even now, these ideas appeal to me professionally and intellectually, I also think there's sort of a moral imperative to what we're trying to do here. So I'm really excited about the progress being made and look forward to continuing to be involved.
Great, thanks very much, Mark. So all four of you started to get into the following question, but I would ask you to elaborate, and that is, from the standpoint of life sciences industry, and let's take this broadly. We're talking pharma, bio, advanced diagnostics, heck, biosimilars, take your pick, life sciences industry, thinking of it broadly, including the R&D innovative component, okay? Including that, what does VBID look like to the life sciences industry? Does the life sciences industry see VBID as an opportunity, a threat, a means to a different end? What does it look like? Mona, I wanted to start with you. The industry is quite diverse, of course, and they're great big companies like Amgen and J&J and Merck and so forth, and they're little startups. They're also important elements of that ecosystem. So what does VBID look like to that industry, diverse as it may be?
So I'd start off by saying that generally, well, regardless of whether it's a big company or a small one, we are generally aligned around the broad concepts of value-based insurance design and using the evidence to base that design for patients. So I really have not seen that there's been any concern about that. What I would say is we are concerned about the level of out-of-the-pocket costs being embedded in the benefit designs. We all know that patients pay more out of their pocket for pharmaceuticals than they pay for hospitalization. So just if you look at the figures, a patient will pay 3% of hospitalization costs, but 14% of pharmaceutical costs. Even though we know that if you look at the totality of healthcare spend, about a third of that spend, so majority of that spend is sitting with hospitalizations, not with the pharmaceuticals. So that's the first piece. The second piece where we do see some concern around is the shifting from co-pays to these co-insurances. And the co-insurance, so by the way, is based on list price, not net price, and I'll come to that in just a second. And we also know that when you increase these co-pays, these co-insurances, if you will, there is a high degree of abandonment. So we are seeing up to 50% of abandonment rates with patients. And we also know this, that when a patient abandons their medicine, 75% of them, 3/4 of them, never go on to anything else. And so when they never go on to something else, we do know that there are sequelae of that which show up in the more expensive care in the system.
Well, I have to just hold on for a second, just stop you there for a second. That's exactly what Amitabh Chandra was talking about.
That's exactly what he was talking about, indeed.
And I'd also want to underline the point you just made. Abandonment doesn't mean I'll switch to a generic. Abandonment means I'm stopping my meds for that condition, which can have really terrible downstream effects. Abandonment is bye-bye and not to return, perhaps, right?
That's right. And then the other piece where there is alignment around is trying to cap out-of-the-pocket costs for Medicare Part D patients. There is broad support that on both sides of the aisle. And we also are really trying to ensure, and on this piece, there is not alignment between our industry and the payer, the industry, but this notion of ensuring that the rebates find their way to the patient at the pharmacy, the counter. So right now, as I'm sure you are seeing, a number of our companies are putting out their results in terms of their gross to net So how much they give away in rebates, those rebates don't find their way at the counter for the patient. What we hear from payers is they find their way to patients through reduced amounts of premiums. So it impacts the premium. But that means that the sick are subsidizing the well, right?
Wow.
Which we don't think is in fact the right approach. And so we do have to get after this perverse incentive of rebates. And I do believe the industry, small or large, as a company, we are aligned in terms of trying to get through from a policy perspective.
So the patient, because of the way the rebates work, the patient is not seeing or appreciating or feeling certain savings or incentives that may be involved in drug selection.
Indeed, if their co-insurance is, if they have a co-insurance, their co-insurance is based on list price, not net. And yet we know that net prices, in fact, could be, you know, almost half that of the list price.
So Cliff, one other
Josh.
point there to just amplify Muna's point is the sick subsidizing healthcare for the healthy is exactly the opposite of how insurance is supposed to work. And the fact that the rebates that are not being seen by patients are being said to help subsidize this, to help provide lower premiums. If the insurance design is a poor one, whether the premiums are low or not is not the point, right? If you're just reducing premiums for really poor insurance or under insurance, that's not helping anybody. So it's a very difficult set of positions.
No kidding. So Christine, so from your standpoint, having heard the comments just now from Muna and Josh, can you add to how does the life sciences industry see or experience VBID?
Yeah, so I guess it depends on if you're a TIGR or an EOR. And I think we both know a TIGR and an EOR affiliated with this organization. I tend to be a TIGR. So I will say optimistically, life sciences companies need to look at VBID as a lever to gain patient access, as a lever to improve the quality of care, as something that you know, changes an access point, if you will, for patients. Life sciences companies will spend countless dollars on reaching out to patients, and you know, whether it's a medication therapy management program or some type of patient support or something like that. And yet we know something like VBID and reducing that barrier improves adherence from anywhere from like 3 to 12%. If you know that, why wouldn't you advocate for that? You could, you know, that's something that's right there then. We see it, you know, with what the discussions we've had about the Affordable Care Act. You know, that type of thing. I think from the EOR perspective, just to kind of be fair and balanced, is, you know, give EORs their due, is I think if you're bringing therapies to market that are either more me too or aren't providing some type of significant value, and we think of value as kind of, you know, a derivative of cost and quality, that type of thing, that if you're not bringing something of value, you might not have the same level of access. You might be put in a position, or for example, to get to the low value care piece, and something that, you know, that Josh was referring to, you know, if it's not being used for the right patient, Mark says constantly, you know, his 3 high value services are also his 3, you know, hated low value services, you know, kind of thing, that if you could, if you are positioning for the right patient for the right therapy at the right time, then it's not low value care. It's not waste. It's not that. If you're just trying to hit everyone inappropriately, that's going to create waste and decrease capacity in the system, decrease that headroom that Muna was talking about, the headroom for innovation, the headroom for you know, these new therapies that Josh and his organization are bringing.
And we're going to come back, and I want to thank you for the headroom issue, and maybe I could push that on Mark at this point. And that is this: is the industry accepting of the premise that if you push away low value care stuff and you optimize care for hypertension, diabetes, and so forth, there will be some headroom for the new stuff, for the stuff coming out of the pipeline. Mark, is there merit to that argument? Does it really play in the boardrooms of big life sciences companies?
I think there's support for it, Cliff. I don't know if it plays that way. I mean, so for instance, I would say most of the innovative industry would agree with Mark that once products go generic, generic substitution frees up room and budgets. So no one's in the business of defending branded end of life, products anymore, and that should free up. But I would say there's almost a built-in bias against new therapies anyway, to restrict them, to suppress their adoption. I mean, what started 20 years ago, just with the rare disease drugs, is now become a matter of doing business in small biotech companies. You have to set up your own reimbursement hub, because people don't understand their own benefits. They don't know if their drugs are going to be covered. So you have to invest in the infrastructure to have somebody actually help people navigate their own benefit design. And I would say, another way the industry has sort of supported the benefit-based or value-based design for many years was copay cards. I know a lot of health plans may not like it, but that was a reaction to when these copays got very high and people didn't take their medication. Effectively, the manufacturers are giving a rebate to the patient in a way by reducing that copay barrier to their care. So the manufacturers are stuck in this in a couple of ways. They know barriers are going to be there. They have to help patients navigate them. They may have to offset them financially. And then the third thing I'll throw in there that we haven't talked about is particularly for physician-administered drugs, the reimbursement around that is heavily distorted and always skews in favor of higher prices, which may not be in the best interest of anyone other than the provider, but that impacts the payer, it impacts the patient. And I've seen young companies where now it's sophisticated enough that the venture capitalists investing in them are saying, tell me about the practice economics of this drug, because they want to know, will providers make money or perceive that they're losing money by use of this drug versus something else? And all that goes into how you have to think about pricing and access to the medications.
So here's what's terribly concerning about the point you just made, and I think most would agree with it. VBID is looking for the ways to use nuance and a few buttons and levers and other kind of techniques to improve decision-making, to optimize decision-making for patients and families. But what you just described, Mark, is basically the fog, not the fog of war, but the fog of healthcare payment systems. It's so messy out there that, as you just said, any company with a new drug has to set up their own payment hub, reimbursement hub. It's just so confusing. And, toss in kind of the PBMs and other aspects and various kinds of contracting. It's hard to get it optimal in this environment.
Exactly.
That to me is disconcerting.
I think that's the problem, because what this whole initiative has done is it's highlighted maybe the microeconomic effects at the patient level and the value perspective from the payer. But there's a lot in between that I would call misaligned incentives. Otherwise, the market would have found its way there. And it's these lack of alignment of incentives or maybe sub-optimization around what the PBM's interests are, what the provider's interests are, that make it so that this is not an efficient system and everybody's sort of, I would say that every low value product or service is somebody's product or profit margin. And it shouldn't take Mark Fendrick's mother to tell us, if you want less of something, then don't pay for it, or don't pay as much for it. You won't get as much of it. I think, Jim Parker and John Rother had also kind of commented a little bit on the payment reform element to higher low value care, which I think has to be part of this.
So Josh Ofman, is this likewise concerning to you? This fog out there that is not getting us to optimal allocation?
It is. I'll go back to my, biotech days. I think what Mark mentioned is critically important, but you actually laid out the case for VBID. So in this fog of perverse incentives, misaligned incentives, and lack of transparency, VBID is a tool that can provide quite a lot of clarity. And using clinical nuance rather than microeconomics, and using a rational approach to establishing what a formulary design or a coverage policy should look like. And again, it makes a huge amount of sense because the incentives are difficult to cut through. And I think a more rational system based on clinical nuance is critically important. And I'll just make one other point. Since I've been in this industry for decades, when we started out, and Mark will remember this, the value part of VBID was pretty easy to figure out. You did a value analysis using traditional value assessment methodologies, and if it was high value, you would include it in your coverage policy or in your formulary. Multiple organizations like ICER and others have done a really good job of conflating this notion of value with budget impact, which is a completely different concept, and confusing the world about it. And so what's been very disheartening to see is the value part of value-based insurance design has gotten more complicated because of this conflation of ideas. Value is a very particular thing. It's not cost savings. It's not budget impact. So if you wanted budget-based insurance design, you would do something different that had nothing to do with clinical nuance or clinical outcomes. But if you're sticking with value-based insurance design, then we've got to get real clear about it. But I think you outlined between Mark and your comments, but the opportunity for VBID, which is to cut through that fog and provide a lot of clarity about what are the benefits that I am buying with my premium dollar. Right now, it's completely unclear to people what they're buying with their premium dollar. And to Muna's prior point, if the money that manufacturers and innovators are putting into the system is not being given to the patient, but instead being given to premium dollars for illogical policies, that's not helping anybody. And so that's the challenge.
Well, and you have just echoed John Rother's earlier point insofar as value is a really complicated concept, and if you're trying to get that patients to start thinking about that, and consumers, they are going to be lost. Use a different vocabulary. Chris, did you have a point?
I did, yes, and it's on that very topic. It's regarding this issue or this thought about clinical nuance, because that's really at the core of what the value is, the value to that particular patient, that particular population of people. And that is, I think, a place where the life sciences organizations have a real opportunity to add value to this discussion, to this advancement, is more generation of real world evidence, putting more of their data into public databases or into shared registries or things like that. Life sciences organizations have lots of data on the patient journey, on patient-reported outcomes, on side effects. They do social media listening, and kind of some of the nuances. So that something that's been very elusive is this clinical nuance component. This is an opportunity to put more of a fulsome picture to that. And to Josh's point, when you're balancing the budget impact piece, you actually have a stronger value assessment piece. You have a clearer, more crystallized picture of who the right patient is. And I think it's, one of Mark's standard slides is, the Star Wars medicine and a Flintstone delivery system. Maybe real world evidence, maybe AI, maybe these types of aggregations of data, especially from the patient lens, could really contribute to this, to a more meaningful definition of what clinical nuance is and that decision making that occurs because of it.
So a steady stream of real world data comprising bodies of real world evidence kind of mitigates risk here and provides for more informed decision making. Great point. So Muna, back to you now. Having heard kind of the round robin we just had about what it's looking like to the life sciences industry, ups and downs and so forth, how, Muna, can the life sciences industry be a more collaborative, constructive partner in the use and advancement of VBID henceforth? There's some upsides and downsides. It is foggy out there. There are a lot of disconnects. It's still suboptimal. How can the industry use and capitalize on VBID as a partner to advance the field? Muna.
So I'll build on the comments that Chris just made. So we, and by the way, this came through in the course of the sessions, even just before this, and that is the personalization of VBID to bring in the nuance. So, I mean, in an ideal world, imagine a world where a patient would go in and based on real world data, based on the predictive ability that we now have, an HIT, that in fact we can say for you, this is what your benefit design needs to look like to give you the best care. That would be an ideal world. And I do believe that over time, if we wanted to get there, we have the tools in our hands. The payers, the providers, the industry has the tools in their hands to be able to move in that direction. The second piece that I would say is there is a greater and greater level of sophistication within the industry now to embed not only the need to get FDA approval for the medicine, but to ensure that this notion of access and affordability are being brought in well before you enter the phase 3. And so being able to think about who is the patient, the population, or what is that going to look like that could best be able to benefit from this medicine, this intervention. I think that is becoming part of the thinking of pharmaceutical firms. And then the last piece that I would add is none of this can happen without a sense of partnership. We've had this conversation about linking of social care and medical care. Right? We have talked about this personalization of benefit design. We've talked about trying to get after care that is inefficient. We've talked about enhancing the adoption of biosimilars. All of this is going to require aligned incentives across the ecosystem. And I think that that is one of the biggest things as a takeaway from this conversation that we have to have, that we'll never be able to progress in this field if it all falls on only one of the players to make the change. I think we all have to do our part, and the industry is committed to being at the table constructively, putting forward a solution and not being viewed as the problem. We want to be viewed as part of the solution.
Okay, and I'll push you a little bit more on that, Muna. So the primary incentive for industry to be at the table of VBID and getting rid of low value care and so forth, the primary incentive is what? If you had to explain it.
The incentive is twofold. The primary incentive is twofold. First is to impact the outcomes of patients, to be able to make sure that the medicines that come out of our laboratories make it to patients, because that is our mission. So that's the first piece. The second piece is we have to be able to balance sustainability in access with sustainability in innovation. If we are not paid for our innovation, that is going to be at the detriment of patients all around the world. So we have to be able to make sure we ensure access and affordability, but we do it in a way that can then fuel us to be able to pay for the innovations for tomorrow.
Okay, so what we're hearing then, and Mark, back to you, Mark Staubach, on this. Just want to bounce this off you now. What we just heard, and it was based on the comments that Chris and Josh and you made earlier. Mona kind of pulled it together to say VBID can and should be personalized. The life sciences industry is more sophisticated now regarding getting FDA approval, but earlier thinking about patient access and affordability, which ought to build on VBID. And third, life sciences industry is a true partner at the table as long as industry sees that this is aligned with the mission of serving patients and supports innovation. So I kind of just gave a Cliff Notes summary of what Mona just said. Mark, are you on board? Does that sound about right to you?
It does. I agree with all of that, but as always, the devil's in the details. I'll give you an example now. I'll say to Chris' point, I'm a bit of a Tigger too, otherwise I wouldn't still be doing this for 20 years with Mark. The ER side sometimes is a frustration with what prevents this from happening. So I'll give you a good example, unnamed company and product. But the idea was, this is very VBID-like. Some patients within the approved indication are at higher risk and have a higher value for a particular therapeutic, right? And there are patients who are at lower risk who, on the margin, don't get the same level of value. Could you price them differently? The health plan was basically saying, look, we agreed for the high risk, but boy, this is a lot of money for very low risk patients. So what I wanted to do is contract with them to say, agreed, let's provide the lowest copay and the greatest access for those high risk patients. And yeah, maybe it's a little bit higher copay for the other patients, but they should still have access if their physician wants it. And you will pay less for that. You'll pay more for this and less for the low value. It's perfectly aligned with this. I could not get it through the legal department, who said, wait a minute, you're valuing some patients over others. And I said, no, from a healthcare standpoint, there is more value in one than the other. And then the final turnaround was, well, if you're paying a higher rebate on the low cost ones, you're incentivizing the health plan to give the drug to the low value people at lower risk as opposed to the other one. So just an example of how these distortions take what should be a high-minded, everybody's aligned around what we're trying to do idea, and kind of in many cases just blew it up. So it doesn't mean we stop trying. I agree with Muna, companies are getting more sophisticated. Plans are looking for more innovation now than they used to in terms of how you might contract with them, but it just kind of shows that even the best intentions sometimes fall flat.
And Cliff, outside of drugs, if you want to move outside of drugs to diagnostics for a minute, we're, as I mentioned, you'd asked me, how does it relate to what I'm doing now around, early cancer detection, genomic blood tests, something that's typically not covered at all in Medicare. And what's been so interesting to be a part of is if you're a commercial payer or Medicare and you have a cancer diagnosis, they'll pay for anything. And even Medicare is saying, well, unless you have a cancer diagnosis, we don't think we should be paying for this technology. And you can see how perverse and non-clinically nuanced that is, because what we're trying to do is detect cancer earlier, where patient outcomes are going to be better, where costs are going to come down. And, it's just, that's how we're going to change the cost structure of cancer. We're spending $25 billion a year on cancer screening today, looking for 4 or 5 cancers that have enormous false positive rates. So most of the screening we're doing, most of that money is being spent on working up patients who don't have cancer. And so we can change all that, but Medicare and commercial payers are saying, well, if you don't have a cancer diagnosis, we're not really interested in paying for any of this new innovative technology.
Well, if there is demonstrated evidence-based value in these early screenings, from the Medicare standpoint, it's like Congress has to get involved. The law is not written that way to support screening. Diagnosis sometimes, yeah, but not screening. So if there's VBID to be had, we need another tweak there. And I don't want to lose Christine's point earlier about real world data building into real world evidence. That is, if you've got an ongoing stream of that, that has to be reassuring. Absolutely. Mark's point is well taken as well. I mean, he's being quite realistic about the opportunities there. So a closing question for each of you then, and I want to make sure I word this correctly. So if you were to say to whoever's in charge of VBID, and it's not just Mark and Mike, I mean, there's a whole set of stakeholders and there's kind of a cohort of people involved, and a network of people involved in this. If you were to say to them, listen, the life sciences industry wants to be a partner here. We've been a partner, we want to be a better partner here. Here's what we would like to see the field go, where we'd like to see the field go. So Mark, Mike, and whoever else you're talking to, how could the field be advanced insofar as methodological approaches, stakeholders, data collection, analytics, what have you, so that the life sciences industry would be a more enthusiastic, collaborative partner, even if it calls on, if they say back to you, here's what we want you to do. So I'll start with Mark on this time. Mark, you're talking to the VBID leaders, as it were, about life science partnerships. What do you want to know?
All right, so Yeah, I've made the point that I think between the payer and the benefit design, it's all the misaligned incentives in the middle. So if I could pick one thing to look at for, I would say for purchasers, for plans, or even for the folks who work on MedPAC, physician administered drugs should be paid based on the service, not on the price of the drug. That's just one example that conspires to push manufacturers to higher prices for their drugs to be used. It has nothing to do with clinical nuance. It's not in the best interests of the payers, and arguably it isn't even the best interest of the patient if the economics of the use of the drug are driving its utilization.
But a very practical point. And you make John Rother happy, by the way. I'm reminding what he just said. So, Chris, what would it be? You're conveying a message to the VBID leadership. How can they make it easier for the life sciences industry to be a better partner?
So I think it's walk the walk, because oftentimes life sciences companies are the ones that ask to put up first, so to speak. Make the concessions on pricing, make the concessions on rebates, make the concessions all around. And to Mark's point about misaligned incentives and Josh's point about misaligned incentives, is start to show that the alignment is happening. So for example, the peanut butter and the jelly, we're getting, the right measurements. We're getting the right infrastructure, if you will, in place. Kavita and Patrick are getting the tools they need in clinical practice to deliver high value care. The data is there, so we're getting the right patient to the right therapy. And then life sciences companies, that means better access to your therapy when it's appropriate. And that plays to Mark's point, pricing, behind the scenes. I'm trying to build on what he said, but it's showing that the peanut butter's there before you ask them to bring the jelly, so to speak.
Some pretty crunchy peanut butter at that, but thank you very much, Chris. Point well taken, nicely worded. Josh, how can we be a better partner in the life sciences industry?
I mean, I think fundamentally, we have to do what we can to create a better economic framework for medical interventions. And I think that it's two elements to it. It's very clear. The first is insurance design. If we don't have a change in the way we're designing our insurance and be a part of that conversation to keep patients at the center of it, none of this that we're going to do is going to help. If insurance design remains the way it is, if that cost shifting continues to occur to the consumer. Secondly, as an industry, we can continue to do things to try to address the economics. I think the advent of biosimilars, I think supporting generic when they're there is important. But I think we're going to continue to innovate, and I think to many of the points made, these innovative therapeutics, innovative testing, innovative diagnostics are going to solve the healthcare cost problem, and they're not the problem. And I think if we don't address insurance designs together collaboratively in a way that imbues them with clinical nuance and is patient focused, none of what we attempt is going to work. And so I do think that's the fundamental, and I'll respectfully disagree with John Rother. Value is a very clear and simple concept. It's been in healthcare for 30 years. I think there's been an attempt to distort it and make it very complicated for very particular reasons. And I think that's doing a disservice to insurance design evolution and to patients.
Actually, John might agree with you. He's concerned that the concept of value is poorly understood, part of which may be derived from the distortion to which you refer, Josh. So still point well taken. And thank you. And I would also guess that you'd be interested in seeing a little bit of flexibility or greater attention to screening as a value-based service. And we
know that we have to move from a break it and fix it healthcare to prediction, prevention, and early detection. Nothing is more valuable than that, but we need to get some real traction around that.
Got it, thanks. Mona, we started out with you. You led off, and I'd like to have you bat cleanup here.
Well, I must say I can stitch all of these themes and just say that because of all of these issues, I think that VBID can serve as a very objective voice in the political discourse that is underway in this country in terms of where exactly we have to shine a spotlight if we are going to get after the issue of healthcare spend in the United States. There is no transparency around where the waste sits and how to get after it. And unfortunately, it takes then this discussion of pricing and drug pricing, even though drugs are only 15% of the healthcare spend. And I believe that the VBID group is in a unique place to be able to serve as that honest broker and objective voice and align the incentives along the points that everyone has spoken about.
So continue to be that stakeholder engaged, objective space. It's kind of pulling all the stakeholders, be the node for these conversations, and pulls together leaders like you. So thank you. Well, Muna Bhanji, Josh Offman, Christine Judet, Mark Stabach, we couldn't have done better. And as some of our other speakers as well, all four of you have bridged industries and careers. And so you've brought a special richness and set of insights to better understanding not only where VBID has been, where it is today, but where it needs to go. And so your openness and willingness to play along with your expertise has been just essential for the advancement of the field. So thank you. And this has been our Manufacturer Viewpoint panel. Reminder of thanks to our first panel on the 2 decades of VBID policy achievements, our second panel on reflections from early VBID adopters, our third panel on consumer perspectives. We could not have done better. And speaking of doing very, very well, I will now turn it over to Mike Chernew. Mike, welcome, sir.
Cliff, thank you. You do a fantastic job every year. So I get to make the closing remarks. Let me start by saying, I think one lesson here is you never want to end with Eeyore. And you want to see me. That's the other message. There. So never end with Eeyore. Thank you to Cliff. I'm going to largely talk about where to go from here. And first, I want to make the following points. There's several points from this slide. The first one is, no matter what year you want to talk about, you can almost always find a year when Tom Brady won something. So when we were thinking about VBID in 1999, you got the picture of Tom Brady on the left. When we published the article on benefit-based copays in 2001. You have the Tom Brady in 2001. The most recent data we could get was in 2018. There's Tom Brady winning the Super Bowl. And in fact, if you want to go then and now, and you really want to get to now, there's Tom Brady now. He is a Buccaneer. In any case, the main points of this slide is not about Tom Brady, but, and you should all know I'm a Steelers fan. When we started this in 2001, and we thought it was really important, healthcare was 14% of GDP. Now it's pushing, in 2018, it's pushing 18. It's higher than that now. The average family premium, even after adjusting for inflation, is roughly doubled. Average family premiums, the share of median income, also almost double. You heard about this sort of affordability issue. These are just some numbers. The out-of-pocket share has risen. For folks. The percentage of people with high deductibles have gone up almost 7-fold, and the amount of those deductibles in a single plan has also gone up a dramatic amount. So however important we thought we were in 2001, this is just a much, much bigger issue now. And so you either might think we haven't really been very successful, or you might think it's more important than ever. I realize I'm the Eeyore. I'm going to go with more important forever. Imagine how bad the world would be without any VBID. And in fact, Amitabh kicked off the whole day pointing that out. So to get to the theme of what I want to talk about, where to go from here, I'll be very brief because Mark's going to text me when I need to shut up. The first one is emphasize low value care. The way I would think about VBID would be, we got into it for the health, we stayed because of the money. And you're just not going to be able to move anything forward until we can find a way to make VBID and access to high value care at least fiscally neutral. And that's going to need some attention to low value care. And again, if you followed what Mark and I have been doing lately, there's a big emphasis on low value care, with a lot of support from a lot of people, many of you. Implementation, there's a huge discussion. I think every panel discussed on aspects of implementation. I'll say a few things. One of them is a lot of emphasis on definition of high and low value and measurement. I'd be remiss if I didn't say particularly of low value care. Mark and I have been working with some folks at Milliman on the health waste calculator to help do measurement, but measurement's going to end up being important. Maybe that just shows I'm an academic. I think it's really important, and you saw on the agenda today, the different stakeholders, that we find the right balance for different stakeholders. What role should each one have? So that's the patients, the providers, the plans, and then the employers. I'm kind of where Jill Berger was, that we really need to push the employers more, but everyone in this equation ends up being particularly important in terms of figuring out what to do and moving us forward. And we have to work on getting the different stakeholders to move us forward in general. That's going to require some more work. And I think Patrick Conway said this early on, we do need to take something that is inherently complicated and nuanced and keep it simple. And I think there's a lot of work on how to do that. I am the vice chair of the Massachusetts Connector, for example, and we have a program in our standard benefit designs, that's the key word there, standard, that simplifies access to services for patients with diabetes, particularly insulin and some related things. So number one, low value care. Number two, implementation. I'll go through a few other very quickly. One, you've heard Mark talk all the time about peanut butter and jelly. What that basically means is we need to integrate benefit design with payment. I think we are getting there, but we're really at the beginning of that mountain of the integration of payment reform and benefit design. And so there's a lot of work to do in that space. There's a lot of discussion today of my next point, which is digital health. I will just say in response to some of the things I think Marge, but a ton of people said this, is telehealth, or more broadly digital health, turns out to be both high value and low value. After the pandemic, it will be both high value and low value. I've been in a lot of meetings lately. People have sent me messages in the chat about how telehealth saved their lives. They were having almost a burst appendix, and telehealth saved them, which is wonderful. But as it is also possible for a lot of not so high value telehealth. Figuring out how benefit design works, and payment for that matter, in a telehealth digital world is unbelievably important. Five, there's going to be a theme, I suspect, ongoing. You should know we've actually focused on this and published in this area for decades on health equity. In fact, I would say one of our big motivations going in was the recognition that healthcare out-of-pocket requirements were rising, which we were skeptical about for a bunch of reasons. But boy, if you're going to charge lower income people more, make sure they have access to their needed services. And I think we're going to be moving into a time where the equity aspects of VBID will be increasingly important, and there's a lot more work to be done in that space. The last one is, I understand we've had the Affordable Care Act, but there's still, I think, going to be a growing emphasis on insurance expansions. I've talked to some folks on the Hill about aspects of insurance expansions. And one nuance in insurance expansions is expansion of what? And I've argued the key thing is to make sure we have expansion to access of high value services. Giving a lot of people coverage, but not very good coverage, doesn't help you as much as making sure that people have access to the high value services that originally motivated VBID. So I think in an era where there's a discussion of expansion of access, particularly in the context of health disparities, but I would argue more broadly access, I think there's going to be a growing role for VBID in understanding how it can help balance the fiscal concerns with the need for better health. So I don't want to really ruin my brand by saying something in the end it's not very Eeyore-ish, but maybe I will. What gives me optimism about all of this, and it was clear today, is VBID is one space where people that generally disagree actually agree. I think Katie Spangler made this point when she was speaking earlier, and I think that sort of ability to fit in this sort of bipartisan, I'm not sure bicameral works in the outside of the legislative setting, but in any setting, you can get patients and providers to agree. You can get payers to agree. it's hard to argue that there should be barriers for services that everybody thinks is high value. And so I do think there's a lot of organizations of goodwill and a lot of stakeholders of goodwill that will help us work on some of the issues that I just raised. So with that, I'm ready for the next slide. The next slide is broadly a thank you slide. I will start with thanking the speakers on the panel. There's many things that are amazing about Mark, but one of them is his ability to recruit absolutely A-list speakers to everything. That includes Cliff, by the way, who's A-list moderator, but the speakers in the panel are absolutely outstanding, both in the job they did here today, but also in what they do in their day jobs. I could not be more grateful to the speakers. I want to be particularly thankful of the audience. We are always astounded at how many people spend time with us. At least until I was talking, there were still literally hundreds of people listening. Now it might just be tens of people, but at least it used to be hundreds of people. And so if you are still listening, we really, really do appreciate the time and engagement we get from folks that attend events like this. It really is not just the number, but the quality of people matter. And of course, the sponsors make it all possible. I express my appreciation, but really from the depths of the hearts of Mark in the VBID Center, a true thanks for all the things that you've done. I hope today convinced you that there has really been a big impact on people's lives for the investment you've made. And I really do, I speak also on behalf of Mark and the entire VBID Center, really do appreciate your support. So again, thank you very much. I want to thank the staff at the VBID Center. They have always made my slides look much better. They keep Mark in line, which is no small task, and they make these things run as smoothly as they do. So the Susan Lynn, Jordan, the rest of the VBID Center team, you really do an absolutely amazing job. So thank you. And as we say every spring, although not every spring in this context, every spring we say next year in the big house. So hopefully these Zoom or GoToMeeting sessions are wonderful, but there really is no substitute for getting to see people in person, maybe get to go on the field and kick a field goal, and learn a lot of things that through interactions that are harder to have on Zoom. So again, thank you all for coming. We really do appreciate your time, and we really hope for your continued support and to see you again in person in Ann Arbor when this very odd year is just a thing of the past. So thanks, Cliff or Mark. I'm turning it back to you to say final goodbyes.
Mark can have it. I'm sending it off to Mark.
Mark wasn't ready to get his hand off. Can you hear me okay, Cliff?
I can. I didn't think that was going to happen either, but Mike sort of decided that.
No, thank you, Eeyore. So I guess we'll just have Tigger say goodbye and thank you. And again, my appreciation to Susan, Lynn, and Jordan and the rest of the team. Here's how you can connect with us. We'll have lots of resources that we put in the chat, put on the website soon. And we look forward to following up with many of you. Thank you again. Have a good rest of your day.
Bye. Thanks, everybody.